And of course,
Doctor, we are live now, doctor.
uh, I think we can start. Need not waste any time.
You can
Doctor,
start the session, doctor. We
Yes,
are
yes.
live now.
start a question. So, yeah, we'll go. So, welcome all and welcome to our 32nd episode of our late night retina sessions. And for for this session, we have today as our moderator Dr. Chitranjan Mishra. He is the current head of VR department at Trilochan Netralaya, Sambalpur, Odisha. So over to you, Dr. Chitranjan, and let's get with it.
Thank you, Avnis, my dear friend, and the brain behind this beautiful late night retina episodes. And thank you to all our core team of late night retina. And Babik is there over here. Thanks, Babik. Thanks to YOSI also. So, in this episode 32, we have PCV, polypoidal choroidal vasculopathy, we are going to discuss. And we have two eminent retina. Young and dynamic retina specialist with us. First, Niroj Kumar Sahu, my younger colleague from MBBS time, and he is from LB Prasad Eye Institute, Vijayawada. And the second panel is Dr. Kushal Deliwala, again a very nice friend, and he is from Netralaya Super Speciality Eye Hospital, Ahmedabad, Gujarat. And the presenters, we have four nice presentations today. The first one by Dr. Dhwani Agrawal. She is Vitretina Fellow in LB Prasad, Vizag. And the second one is Dr. Dipanshu Agrawal. He is from Chaitram uh, Eye Hospital, Indore. And we have Sisir, Sisir Varghese, very good friend. He's from Amrita Eye Hospital, Tiruvalla. And last one, again, a very hardworking fellow from our Arabian time, Dr. Aarti. She is from Rajan Eye Care, Chennai. So, without wasting much time, may I request Dr. Dhwani to start her presentation. Her presentation will be the first one. Dr. Dhwani, please.
Thank you, sir. So we'll be discussing about polypoidal choroidal vasculopathy and the diagnostic modalities and the classical signs associated with it. The objectives of my presentation is to discuss a case of PCV and highlight classification and classical signs in different diagnostic modalities. So we all know that PCV is a recurrent exudative maculopathy that happens due to the weakening of inner choroidal vessels, which leads to multiple recurrent serosanguinous or hemorrhagic retinal pigment epithelial detachment. It shares a morphological characteristics with neovascular AMD as well. So we have a 81-year-old male walking to our OPD saying that he has sudden onset diminution of vision for 15 days unilaterally. He's a known case of asthma and hypertension. And this is the fundus photograph for right eye. If I zoom in into the posterior pole, we can see a serosanguinous PD right in the center of the fovea with associated subretinal fluid and some drusense temporal and inferior, and a massive subretinal hemorrhage temporal to this along the superotemporal arcade. The best corrected visual acuity for right eye for this patient was 20/25 N6. And in the left eye, although the posterior pole was sparingly involved, we see some coalesced medium to small drusense along the superotemporal and inferotemporal arcade. If we look at the OCT scan for the right eye for this patient, we see a large PD subfoveally associated with subretinal fluid. There was also hyperreflective back shadowing temporal to this PD correlating with the subretinal bleed that we saw clinically. There was double layer sign which could be appreciated nasal to this large PD. And as we can see in the vertical section, there was notch PD or complex PD as we know of, with dilated halar layers. And if you look at the scan 8 here towards the right, we see a classical M-shaped PED for this gentleman as well. And the left eye showed dilated halar vessels and no significant signs of any PED. So what are the OCT findings that you can find in PCV cases? If you look, one can find a sharp peak PED, as you can see in this scan A, with an inverted V configuration, with one of the edges having at least an angle of 70 degree, and the height is always more than the base. One can also have a sub-RP hyperreflectivity ring-like lesion, as you can see in the B scan. A notched PD or a complex PD, as we saw in our case, associated with subretinal hemorrhage, is also one of the major criteria in the diagnosis of PCV. Along with it, dilated halar layers, fluid compartments in intraretinal space or subretinal space. And on NFAS OCT, one can also find a hyperreflective branching network associated with multiple PEDs. So when we went ahead with the newer diagnostic modalities for this patient, although for this patient we weren't able to find any BVN or a polyp due to poor segmentation and motion artifact. But as you can see in this picture, one can find different patterns of BVN on Octa in cases of PCV. Three major patterns that have been identified are CFAN, medusa, and tangle, otherwise also known as glomeruli, stick, or trunk. Not only would these patterns help in diagnosis of PCV, but also in prognostication. CFAN and medusa patterns are usually non-foveal, although they have more recurrence, but because they're non-foveal, they will have better response to combined therapy. While tangle is more often associated with pachychoroid spectrum and has poor response to treatment. One can also see a draining or a feeder vessel as seen as in B1 and B2 in a polyp in choriocapillary slab. So this is the gold standard treatment for investigation for PCV and ICGA. We see early hyperfluorescence as marked as 1, which is the branch vascular network. And within 6 minutes, in the second frame, we see marked as 3, a hyperfluorescent focal polyp surrounded by hypofluorescence. And as we go to the subsequent frames, these hypofluorescent halo is becoming more hyperfluorescent due to the leakage, showing activity of this PCV. And the subretinal hemorrhage that we saw shows blocked hypofluorescence throughout in all the frames. In the left eye, the pachyvessels could be more remarkably seen and as marked with the asterisks in all the quadrants. And at late phase, we see some staining, hyperfluorescent staining where the drusen's were seen. So if we talk about what all features we see for a PCV in different phases of ICG, early phase will show an AVN or a BVN as we saw in our case. Mid phase is the best to pick up a polyp that is leaking, and late phase could show a large geographical hyperfluorescence, often in a pattern of rosette, or it can also show a window defect, an RP window defect. If you want to pick up an active PCV, 3 important features to remember are first being intraretinal or subretinal fluid, a sub-RP or subretinal hemorrhage, and a vision loss of more than or equal to 5 ETDRS. You can also associate it with the leakage that would be seen on FFA or ICGA. So we at this point of time, we know we are dealing with hemorrhagic PCV and it is active, and we injected this gentleman with intravitreal aflibercept. And after a month, we see the PD is flattened. There's minimal residual SRF which is present, although notched PED is still persistent, but there's definitely a decrease in activity right now. So we have already discussed what are the classical signs in various diagnostic modalities. If we talk more about the classification associated with PCV, it could be quiescent or active. Active will have either hemorrhagic, exudative, or mixed. A quiescent PCV will have presence of polyp without any subretinal detachment or hemorrhage. Hemorrhagic, as the name suggests, will have either sub-RP hemorrhage or a massive subretinal hemorrhage associated with it. Exudative will have more of exudation, and a mixed could be predominantly hemorrhagic or a predominantly exudative one. More recent classification that has been suggested is an OCT based, which classifies it PCV into pachychoroid and non-pachychoroid PCV. While pachychoroid PCV will have more features similar to a chronic CSC and will has been shown to respond less to anti-VEGF treatment. A non-pachychoroid PCV will be more similar to a AMD case and will have rapid resolution of fluid with anti-VEGF treatment. When we're talking about large PDs and anti-VEGF treatment, a very dreadful complication that can happen is RP-RIP. And it is important to tell the patients about this also. So how to identify an RP-RIP on fundus photograph is where the RIP is there, we'll have a subretinal linear pigmented a hyperpigmented lesion, and just around it will be a hypopigmented lesion, usually associated with specks of hemorrhage. An autofluorescent will show hyperreflectivity where the RP has scrolled or retracted towards, while a hypofluorescence in the area of the defect. One can also pick it up on OCT as a scroll of RP that is.
Dhwani, excuse me. Very nice presentation. Just these discussions we'll keep for the panel. Just tell the silent features of your case pertinent to this. Yeah, continue.
So we saw that in my case, first of all, in the fundus photograph, we saw a polyp associated with massive subretinal hemorrhage. On OCT, we saw a large PD subretinal fluid and double layer sign. On ICGA, we saw a BVN and an active polyp. All these helped us with the diagnosis of PCV and certain the treatment associated with it.
So great case, Dhwani, definitely, and very nice documentation. We'll keep the discussion after the second presentation. We have clubbed these two. May I request Dr. Dipanshu to please present. Dr. Dipanshu.
Is it visible?
Make it full screen, Dipanshu.
Is it full screen now?
No, now it is. Yeah.
All right. Very good evening. Thank you, Dr. Avnish and Late Night Retina team for giving me this opportunity. So after a brief discussion on the classification and how to diagnose the entity, my talk will be limited to two cases. My first case is of a 65-year-old businessman who presented with diminution of vision in the left eye since 1 month. There was no significant past history. On the right eye, best corrected visual acuity was 20/20. And on dilated fundus evaluation, we could see attached retina with these confluent medium to large size drusens along with this drusenoid PED. However, in the left eye, best corrected visual acuity was 20/200 on anti-segment was within normal limit. And when we did a dilated fundus evaluation, we could see an attached retina. However, there was presence of this massive subretinal heme along with subretinal exudation, which was present around the fovea and extended inferotemporal of the macula. So when we did an OCT to the right eye, we could see these multiple drusenoid PEDs. However, OCT through the left eye, through the fovea showed that there was mild disruption of the foveal contour. There was presence of these hyporeflective intraretinal as well as subretinal spaces which suggested of fluid. There were multilobulated PEDs along with backshadowing suggestive of hemorrhagic PEDs, and this along the inferotemporal arcade where we could see this massive exudation which corresponded with subretinal hyperreflective material as well as hyperreflective spaces with suggestive of fluid. On OCT, however, did not come out to be very significant. We could see some branching network here. So we diagnosed this case as polypoidal choroidal vasculopathy and started advised the patient intravitreal anti-VEGF. We advised brolucizumab in this case, and we also told the patient that first there will be loading dose followed by maintenance dose as multiple injections would be required. So loading dose at 6 weekly interval were given, and after the first injection, we can see the vision has slightly improved to 20/100. Foveal contour has slightly regained its normalcy, but the PEDs have slightly started reducing in height, and there was reduction in the subretinal hyperreflective material. However, the exudation still persisted. This is after the second injection where we could see marked improvement in the subretinal hemorrhage. There clearing up of the hemorrhage, exudation still persisted. PD started to reduce in size and clearing up of the subretinal fluid and hemorrhage. This is after third injection where we can see significant improvement of visual acuity to 20/64 with initial presentation of 20/200. There was absence of subretinal heme and exudation has also cleared up significantly. and the PEDs had reduced to significant height, and subretinal fluid was also cleared up. So patient was advised 2 monthly follow-up. This is after 2 months of fourth injection, where we could see a reduction in the vision, and there was the foveal contour also was disrupted. There was again a recurrence of the subretinal fluid, with PD height also increasing compared to the previous visit. So we advised the patient fifth injection, but patient had undergone fifth injection, but yet to follow up after this visit. So this is week on week, the visit on visit comparison after every injection, where we can see nice clearing up of the subretinal heme and exudation on after 4 injections, and also there was significant reduction in the PED height along with subretinal fluid, but there was some amount of recurrence seen after the fourth injection. Patient is yet to follow. So this is a second case, a brief case, where patient presented with visual acuity of 20 by 600. There was cataract, so their picture quality is not very good. Here we can see a polypoidal lesion along with some surrounding exudation. On OCT, we could see this hyperreflective intraretinal cystic space along with this tall PEDs with some back shadowing. OCTA was not very good quality, so I have not put it. So we diagnosed this patient again as PCV and advised patient intravitreal brolucizumab. This patient also we advised multiple injections, but after first injection, we could see that wow effect of the brolucizumab, which we usually talk about. There was significant reduction of there was complete normalcy of the retinal architecture. However, there was mild thinning of the fovea we could see on this OCT, and vision improved to 20 by 200. Patient followed up after 3 months, where the vision dropped further to 20 by 400. There was presence of again intraretinal cystic spaces, and PED again reappeared. So again, injection was advised. Patient has taken the injection and yet to follow. So I would conclude by saying, quoting this article which recently got published in Ophthalmology Retina in 2024, where they stated that PCV subtype makes up a large percentage of NAMD, not only in the Asian patients, but also significant. It is significantly high in the Western population. PCV also forms up a significant portion of the patients with neovascular AMD, but it is often not recognized because of lack of ICGA or attention to other diagnostic findings. Of all the neovascular AMD, PCV subtype constitutes nearly 50% in the Asian population and 20 to 30% in the Western population. So PCV can have variable outcomes. Like in my first case, it required multiple injections. However, in the second case, with only one injection, we could flatten the retina. And near molecules have advantage with the newer molecules is that it has prolonged injection interval. Thank you.
Yeah, thank you, Dipanshu. Thank you, Dhoni and Dipanshu. Very nice cases. So, starting from 1982, when Lawrence Annuzzi in the Macular Society meeting, he presented about idiopathic polypoidal choroidal vasculopathy for the first time. We have come a long way in the investigational modalities and injections and PDT and whatnot in the management of PCV. So again, a lot of our viewers are residents, and all of us know that during our residency, ICG and PCV are almost synonymous. Like you must know ICG for PCV and vice versa. So with this, may I ask our panel, Dr. Niroj, the role of ICG in the diagnosis of PCV. Niroj, please.
Thank you, Dr. Chitranjan. First of all, very nice cases, very nice presentations. Dr. Dhoni has already mentioned some of the features of PCV that we see on ICG. I'd just like to emphasize that the two components that we commonly see in the branched neovascular network and the polypoidal lesion, they appear at different time frames of ICG. So one thing to be kept in mind is the BNN to be seen at around 1 minute of ICG injection, while the polypoidal lesions can be seen around 6 minutes of injection diet. And some of the other features of PCV on ICG that was not mentioned was we commonly see halovessel anastomosis can be seen sometimes, the much more recent finding that has been described. And the other findings include late geographical hyperfluorescence and choroidal vascular hyperpermeability that we commonly see with PCV. This is based on how we diagnose or detect PCV, but we can also use it for follow-up of PCV eyes uh, to look for polyp closure dates. We can repeat not just at the baseline, we can repeat at around 3 months to 6 months to 1 year and see if the polyps are closed or not. So this is how ICG can be used for detection and follow-up.
So regarding repetition, Niroj, you mean to say after the treatment is started and like after 3 months of the treatment you told, or is it
If at
so?
all it has been performed at baseline, we can repeat at 3 months and see if it is regressed or not. That is how we can repeat multiple times and see if the polyp closure is there or not. If at all you are aiming at polyp closure, so that I'm talking about two terms here. Polyp closure is one and polyp inactivation is one. What we see with monotherapy, anti-VEGF monotherapy is more of polyp inactivation. But if you are aiming for a polyp closure, either with PDT or focal laser, if you want to see that the polyp is closed or not, you can repeat the ICG at these time frames.
Yeah, so thank you, Neeraj, point well taken. So at this point of time, many of our viewers, there will be one question in their mind that ICG is not available in all the places. So that's very much pertinent. And with this, we extend the question to Dr. Kusal regarding the diagnostic features on OCT mostly and OCTA regarding PCV. Kusal, please.
Yeah. Thank you, Dr. Chitranjan, and nice presentations by Dr. Dhwani and Dr. Dipanshu. So we all know that Dr. Dhwani has already showed in her presentation 2 slides, the landmark paper of Jemi Chung et al. Because OCT goes hand in hand with all the retinologists, and the preferred ones are the spectral domain OCTs with EDI or the SWEP source, whichever in OCT is available. So in that, the landmark paper which I am quoting, they have shown that 3 major criteria can be seen on OCT look for the PCV findings. So first one was the sub-RP ring-like lesion where we could see an hyperreflective border with a hyperreflective center. The second point which they had mentioned was the on-fast OCT where it showed an elevated RPE complex that correlated with the PCV network. And the third one was the sharp peak PED. So if we see these 3 major criteria, then the specificity of diagnosing the PCV goes as high as up to 91%. Apart from that, they had also mentioned few minor criteria which can be clubbed with the color fundus photograph. So the minor criteria on the OCT which they had shared was the double layer sign where we can see the RP undulations and underneath the that Brooks membrane. This was clubbed with thickened choroid with dilated Heller's layers. But lot of times we see that the thickened choroid might not be there because there can be an attenuation of choriocapillaries also. And the third minor criteria was complex and multilobular PED. So these were the criteria which can be seen by all the retinologists to confirm on OCT whether we are treating a PCV or are we looking at the AMD. The neovascular AMD we can differentiate also with the help of the choroidal thickness, because in neovascular AMD it will be more of a thin choroid compared to the PCV. And coming to the second part of your question, Dr. Chitranjan, regarding the OCT angio, we all are using OCT angio nowadays, but of course, there are also challenges of the non-availability of the OCT angio also. What I have observed is that OCT angio is useful to detect the BNN, but regarding the detection of the polyps, as Dr. Dipanshu also showed in his presentation, we are not able to clearly localize the polyps because there are certain challenges regarding the turbulent blood flow within the polyps also. And apart from them, if we have those tall peak PEDs or the multilobular PEDs, then there are also challenges regarding the segmentation errors or the projection artifacts. So we can combine OCT angio if it is available along with the classical non-ICGA OCT signs which has been described, and that can improve our understanding as well as further treatment. Thank you.
So, thank you, Kusal. May I request Dr. Dhwani to please show the OCT pictures that will even make more dynamic the discussion. The OCT pictures in the PPT. And as an extension of this to Niroj, the OCTA that he has described and ICG that you told, there are studies we all know. They have compared like the agreement between OCTA and ICG. What is your take on that? Like, will it replace or at least somewhere become similar to that OCTA and ICG for the detection of PCV?
For detection of the polypoidal lesion, definitely ICG scores over OCT angio. OCT angio, it's very difficult to detect those polypoidal lesions. But at the same time, if you're talking about the BNNs, OCT angio can pick up those smaller, even smaller lesions very well compared to if ICG. Now, the ICG that I'm talking about is CSLO-based ICG. Flash-based ICG is again very difficult to pick up, even sometimes polypoidal lesions and the BNNs. But for if you're using a CSLO-based ICG camera, then the polypoidal lesions definitely ICG is a far superior to than OCT angio. At the same time, I'll just like to add here that some studies have also shown that uh, how the polyps look. Some polyps look on OCT angio. They sometimes they have shown that it looks like a tough vessels, which actually is seen as a polypoidal lesion on ICG. But often we do not see polypoidal lesions on OCT angio. But apart from that paper, which shows a tough vessels at the location of polypoidal lesions, it's very difficult to pick up polypoidal lesions on OCT angio.
Yeah, so point is very well taken that out of the polyp and branching neovascular network, the second one, that means the neovascular network can be detected on OCTA. So there are two questions. May I request the panel to take this? One is by Dr. Dibya. Differentiating features of neovascular ARMD from PCV on OCTA. Either of Niroj or Kusal.
Yeah, so I will take it. So as shared before, because we have to also go multimodal imaging, because only OCTA will not help us, because lot of times those patients who were previously being seen as CNV, after the utility of the OCT angio as well as the spectral domain with EDA and swab source have turned out to be diagnosed to be PCV. So one differentiating feature which I usually more emphasize is on the thickness of the choroid. And typically, if we look at the neovascular AMD patients, we also have to look at how they respond during the treatment also, because we know that the prognosis wise PCV patients and neovascular AMD patients behave differently. So lot of times the serial OCT angio also gives me a clue how the lesion is regressing, because initially though we start sometimes treatment with anti-VEGF monotherapy, if we find those patients who are not responding very nicely to the loading doses, then also we have to think retrospectively whether it was PCV or not. And another few findings which I would like to club with the OCT angio will be the amount of exudation. Lot of times it is in PCV more compared to the area of the lesions. So that also sometimes gives us a clue. And rest all features of the OCT which we have discussed. So I always prefer to go for multimodal imaging rather than only go for a pointer on the OCT angio itself.
Okay, thank you, Kusal. So, one question and quick response from Sisir. He has already answered. So, again, Sarat, one of our core members, is asking that any role of FFA in the detection of polyp. Sisir, can you quickly address this, please? Sisir.
Yeah. So, no, I was just telling him that on FFA, you cannot see a polyp because it's a sub-RP lesion, the polyp, just like a type 1 occult CNVM, where the neovascular network is under the RP. So your FFA will show anything which is over the RP, like a type 2 CNV or like a type 2 CNV where you can actually visualize it like a classic CNVM. So polyp or type 1 CNVM, anything which is under the RP, you cannot actually see it on the FFA. You require an ICG also.
Great. So that's why we have all kind of questions and answers from the residents questions like bye kind of. I think Sarad wanted to make something bye kind of question. Also, we have advanced questions. So with this, I'll go to the next question, like the next discussion. We have the different evidence-based medicines for the management of PCV from Everest study, laptop study, Everest 2, and Planet. So from the evidence-based medicine till the practice pattern, so how the intravitreal injections have evolved. Uh, Anyone of Kushal or Niroj can take, and Dr. Bhavik is also there. I would also like to listen from him. Bhavik and Sarath. Yeah. Niroj, you want to take this?
Yeah, so we have seen so many studies with respect to anti-VEGF monotherapy and combination therapies. Starting from Everest and Planet, if we start, they have shown very good outcomes, visual outcomes, I'll say,
Yeah.
in terms of if your patient is on anti-VEGF monotherapy. And they have also documented good polyp inactivity ahead, as I had mentioned previously. But if you are talking about polyp closure rates, a combination therapy scores over again anti-VEGF monotherapy. But as these studies have shown us that anti-VEGF monotherapy is non-inferior and can be continued in cases where polyp closure is not aimed or it is not possible in terms of visual acuity gain. Now, moving forward to more recent molecules, even the Hawk and Harrier of the Japanese arm, they showed very good responses, along with the ability or the advantage of extending beyond 12 weeks in a large majority of patients, almost 70% of eyes, they could extend beyond 12 weeks compared to just 40% eyes in Planet study. So that is one advantage of brolucizumab, I'll say. And we all know the recent faricimab molecule.
Okay, great. So, Kusal, you want to add something to the newer molecules in the management of PCV?
Yeah. So recently, hello. Yeah, am I audible?
Yeah,
Yeah.
yes.
So recently, everyone is aware that faricimab molecule is already being used very much nowadays. And if we look at the effect of the faricimab, whatever the literature is available, it has shown that the outcomes with faricimab monotherapy are also non-inferior to the aflibercept monotherapy, which was again a very landmark Planet study where they showed that it is non-inferior to uh, PDT. Now, the existing studies, they have not actually gone through the subgroup analysis, but recently the ongoing study, that is Salvin study, it is has enrolled patients from the Asian countries, and they are looking into phase 3 and 4 efficacy as well as durability of the faricimab. And the initial data which has come out and was presented in the APVRS 2024, it's looking promising. And the advised pattern will be the same for faricimab also, which includes 3 loading injections and subsequently followed by the treat and extend regimen. So that I would like to just share.
Okay, so Bhavik, can you add something to this? The intravitreal injection for PCV. Bhavik, are you there? If not, Sarath.
Yeah, very nice discussion on injections. But practically, when we are thinking, we need to see. I feel in clinically, in our my experience, the wow effect we see with the brolucizumab injection than the Eylea injection. Multiple studies have shown that they are both are non-inferior. But with the brolucizumab, also we have seen the rebound effect. After the injection has gone, it rebounds very quickly. Also, the same amount of fluid and the polyp elevation what we see is so it requires repeat injections also. It doesn't makes that nowadays the newer injections which are there, the Eylea or faricimab or the Pagenex, it doesn't means like the patient is not affordable. Still, I go ahead with ranibizumab as an initial injection. they will also work better. But if you see the efficacy wise, definitely the newer injections are better. It should not stop us to not to give ranibizumab injection or bevacizumab injection if the patient is not affordable.
Okay, great, sir. So, one final question on this injections to neurons. Suppose we have, say, aflibercept versus faricimab versus brolucizumab. At this point of time, are we having enough evidence from the literature to like pick one over the other? Anything, or it's how it is?
My go-to drug against till now is aflibercept. I usually start with that because again due to the concerns of inflammation in the bevacizumab injections. And faricimab, I'm still waiting for the results, but definitely hopeful that it will turn out to be good. But till now, my go-to anti-VEGF in PCV is aflibercept.
Brolucizumab?
Faricimab, definitely the wow effect is there, but I have a concern of the inflammation side of
Yeah,
it. I
correct.
recently had one event of vasculitis, so I'm back foot right now.
And regarding the faricimab, that you know the USP of that is say 3 to 4 months you need not give the injection that we all to the say to
Yeah.
the patients. So of course, someone who is having a switching injection for faricimab, we give it after 1 month. We give it we give it after say 2 months or something. But someone you start fresh, then are you like giving 3 injections? Then that. 4 monthly, or from the beginning only 4 monthly you people are giving?
Again, as per if you plan to go as per the studies, we have to give that loading dose and see the drying of macula. After that, you start extending. So I tend to give that loading dose, but that can vary based on the initial response of the patient. But I wait till the drying of the macula and then extend rather
Great.
than extending from day one.
Yeah. So thank you. We had very good discussion on first two presentations, and with this we'll go to the third presentation that is by Dr. Sisir. So may I request Dr. Sisir to present?
Yeah, can see the screen, right?
Yes, Sisir, we can see.
Yeah, so thank you, Late Night Retina, for this opportunity. So I'll be talking on extramacular PCV. So no financial interest. So this is the first case. So this was a 60-year-old male, diabetic hypertensive on meds, routine follow-up. BCVA was 6.6 in the right eye and left eye was also 6.6. Now before this history, he actually had come 1 year previously and for a routine evaluation. And then this was his OCT that time. So as you can see in the left eye, there was this serous kind of a PED there, just juxtafoveal to the juxtafoveally. And if you look at the choroid, it's actually quite thick. You can see the dilated pachyvessels underneath. So he was advised follow-up. So that was one good thing he did. He was on follow-up with us. And this was the OCT angio at the time before the history which I just gave you. And you can see the small network over there on the OCT angiography, which is like a subclinical CNV overlying a thick choroid. So this was that time. So now he has again come for a routine evaluation as he was on follow-up. So this is a right eye. Right eye has got an epiretinal membrane. The left eye, you can see, has got a grayish white lesion, just juxtafoveally adjacent to the fovea with some little bit of whitening there, as you can see. And this was the autofluorescence of the left eye, which showed a hyper autofluorescence there to some area of some granular autofluorescence centrally there. And then when you do the OCT, you see the fovea is okay, but then juxtafoveally there is some subretinal fluid. The PED has become like little bit serosanguinous kind of a PED. And you can see the thick dilated, choroidal vessels underneath the lesion there. And this was the raster OCT. So there was this double layer sign which you could see above that subretinal fluid. And then now the PEDs had increased in size. Now it was like a little bit of a notched PED with some hyperreflectivity within it. And multiple PEDs could be seen. And this was the EDI of the right eye, which again you could see the dilated, there's a thick choroid which could be seen. So went ahead with an FFA and ICG. So FFA showed an occult leak just juxtafoveal in an early phase. And on the ICG, you can see the, the Pachy vessels underneath lying there, those thick dilated choroidal vessels can be seen. And there is some sort of an hyperfluorescence there, just again temporal to the fovea. And as you go progress, this is now 1 minute, 14 seconds. You can see a small polypoidal lesion emerging up there along with a branch vascular network. And then we go into the late phase, this is 7 minutes. You can see the polypoidal lesion there, just temporal to the fovea. And then this is even later and it's again leaking. There you can see the lesion clearly now, the polypoidal lesion just juxtafoveally. So we did a ILIA injection plus a focal laser. So he agreed to an ILIA. And now after 1 year of treatment, now he has not taken any other treatment after this, after that ILIA. And this, you can see the scarring there on the autofluorescence. You can see the hypoautofluorescent lesion there, means it's kind of scarred there. And then this is the OCT after a year, no fluid at all, just this little bit of a double layer sign, what you can see with some little bit of an atrophy of the photoreceptor, localized atrophy. The PD has also collapsed, more like a little bit filled with this hyperreflective material, which probably could be a little fibrosis or scarring. And then this is the OCT angio. Now this OCT angio actually shows a little bit of a network, but then it's actually quite stable and it's not had any recurrence as of yet. And he's still on every 4 monthly follow-up. Means I told him specifically 3 times a year follow-up at least, and to report if any symptoms. Now coming to the second case, this is a 54-year-old lady, hypertensive on meds, sudden visual blurring in the right eye. BCVA was 660 in the right eye and the left eye was 618. Now, before this complaint, she came 1 year previously, and you can see that time the vision in the right eye was 6.6. She had a PED there, a serous PED with some hyperreflective changes there, and in the left eye she had an RP atrophy kind of a lesion there. So this was the EDI OCT of the left eye. That time you can see an RP aperture there. It's not a rip exactly, but like an RP aperture with some foveal atrophy. And you can see the dilated thick choroidal vessels underneath. So this could probably be like a resolved CSE or like a chronic CSE which is resolved. And then these could be due to the pachychoroid or pachychoroid disease. And then at that time, the right eye OCT was done, which again revealed this double layer sign. There was no subretinal fluid. And then this was the raster through the serous PD, which I showed you on the fundus photo. So this was the OCT done 1 year previously. And I advised her again every 3 to 4 monthly follow-up just to have a look what is happening. But she did not come, and she comes after a year with this. So she came with a vitreous hemorrhage. And now you can see the hyperreflective yellowish thing that is actually the old subretinal heme. And adjacent to that, there is again fresh subretinal heme, which you can see there, and this total vitreous hemorrhage. So this was the OCT raster. Now the fovea is also lifted up. There is heme underneath the fovea, and then you can see these tall PEDs, peaked PEDs. There multiple PEDs are there, and even above the disc on this third OCT raster, you can see these PEDs. So we advised injection ILIA followed by at least we didn't know how much we'll be giving, so we gave one injection ILIA followed by focal laser. So this is after 1 ILIA. You can see the resolution of the subretinal heme has completely resolved. The PEDs have collapsed there. There's a little bit of heme still left, but the PEDs have completely collapsed, and even the size of the PEDs have reduced, which are just above the disc there. And then after this ILIA, we gave 1 dose of this thing, focal laser, and again repeated an ILIA so that the vitreous hemorrhage will also clear a bit. And the fovea is completely dry. The PEDs have collapsed completely. This is a little bit of scarring, what you see there, or fibrosis. Just above the disc also, there is collapse of the PEDs with some fibrosis. And this is the fundus photo on follow-up at 9 months after the treatment. So she has only received till now 2 ILIA and focal laser. And this is the fundus photo after 9 months of treatment. Vision has come back to 6.6. There is this PED was also lasered. There is scarring there. There's some laser marks there, which has caused some fibrosis up above the disc there. And then this is the OCT raster you can see at 9 months post-treatment. There is still a small double layer sign, but she is inactive. She doesn't have any subretinal fluid. And now she is well aware and she is on follow-up. So to conclude, so close and long follow-up is required for these patients. PCV, anti-VEGF plus focal laser can be considered in this era when PDT is not there, especially for extramacular PCV. So well, you can either do it ICGA or OCT guided. But only thing is you have to personalize the treatment to each patient when they present with such polypoidal lesions. So thank you.
Thank you, Cecil, for the nice presentations, nice cases, and well documented. And just to emphasize one more additional OCT biomarker, that is double layer sign, what CC has told multiple times in his presentation. So basically, double layer sign is not exclusive to PCV. We get to see it in CSR also. The difference being the hyper reflective metal that we get between the two layers in PCV, where it is hypo reflective in case of a CSR. And with this, may I ask Sisir his take on the role of focal laser for the management of PCV, and the settings that you do, or what grade of burn you aim for in a case of PCV focal laser, Sisir?
Yeah, so actually, so there were two recommendations actually. One which was done during 2018, and the other recommendation is after the 2021, especially when PDT became less available. So the first recommendation is that if the polypoidal lesion is juxtafoveal, that is between 200 to 500 microns, then the ideal treatment is with photodynamic therapy and three loading doses of anti-VEGF. If the polypoidal lesion is beyond 500 to 1000, if it's between 500 to 1000 microns, then again the treatment there will be depending on the size of the lesion. If the size of the lesion is less than 1000 microns, then again you will be doing a focal laser. If the size of the lesion is above 1000 microns, then the treatment would be again PDT plus three loading doses of anti-VEGF. Now the recommendation has changed slightly a little bit because of the non-availability of PDT. So now the recommendation is if the lesion is beyond 1000 microns, then only you should do a focal laser. Whereas for the other two lesions which are within 1000 microns of the fovea, then the treatment is still anti-VEGF monotherapy, preferably with aflibercept. And coming to the settings of the focal laser, so you want a nice to burn the polyp very nicely. You need a nice, grade 3 kind of a burn there. So it depends on eyes with, cataract or with hazy media. If the media is hazy, then you'll require slightly more higher power. Or the standard recommended settings would be 200 power. 50 to 100 micron will be the spot size, and a duration of around 100 to 150. So something similar to a PRP, but you be careful of where the lesion. If it's too close to the fovea, I would reduce the power and I will also reduce the spot size. So, and if the lesion is beyond 1000 microns, then I will do like how the settings you keep for a pan-retinal photocoagulation.
And the size of the lesion as detected on ICG or FFA is okay for that also? Like
the size of the lesion, ideally, if you have ICG, that is the best. But if you do not have an ICG, then you can go with an OCT guided focal laser too.
OCT guided, okay. And Saswat is asking whether it is green laser or yellow laser or anything will do.
Yeah, so in my setup, I have been using the yellow laser. So you can definitely do with the green laser also. The settings are the same itself.
Niroj says it's red laser. Niroj, you
Yeah,
want to
that's
say?
red is basically the diode. The diode is the best. It's slightly painful, but if you have the diode laser, you can definitely do the diode. The choroidal penetration or the depth is much better with the diode laser, but leaves a little more amount of scarring as compared to the green and the yellow.
Okay, so any role of TTT for PCV?
Yeah, so TTT has been basically described for, especially like an LIO TTT has been described for lesions which are peripheral, like for PHCR lesions. There is where, even TTT or even a focal laser, peripheral LIO laser has been mentioned. But personally, I don't have any experience with doing TTT for these lesions.
I think subthreshold TTT is something which is also described for the foveal.
That is for CSR, especially when you don't have PDT available. Then you can do a subthreshold TTT for CSCR, chronic CSCR, not acute, chronic CSCR.
Okay, okay. So also Cicero has covered the PDT and injections with this. So one question, the duration or the interval between PDT and say a hypothetical situation, suppose we have PDT with us tomorrow and the injections we want to plan. So what should be the duration between PDT and intravitreal injection?
Yeah, so again, PDT, it depends on what type of a PCV it is. If it is an exudative PCV, we can, if the patient is willing, then you can go ahead directly with PDT plus a intravitreal injection of aflibercept or ranibizumab. That's like a combination treatment. But if there is hemorrhage, then the ideal treatment is anti-VEGF monotherapy till the hemorrhage clears. Do an ICG, see where the polyp is, and then you do a PDT based on the greatest linear dimension. So that is what is ideally recommended. And regarding the duration, 4 days to a week. So 48 hours, anyways, the patient cannot go out of the room post PDT because of the photosensitivity effect and all that. So it's ideally done 4 days to a week after the PDT, where you can do the anti-VEGF injection.
So great points again, Sisir. Just going back to the first presentation of Dhwani, she was telling something about the RP RIP, because we are discussing the management of PCV, and RP RIP is something which comes during the management and during the discussion of the management of PCV. So any risk factors or how to prevent this RP RIP, and also I'll club the role of steroids, maybe systemic or intravitreal both, for this condition, for Kusal and Neroz, both of you.
Yeah, I will go first. So, as you correctly said, there is always a high chance of the RP because of the acute inclination of the tall PEDs. So, as you correctly said, that there is a paper published by LV Prasad Group almost in 2015, where they showed that systemic steroids as an adjunct can help to prevent this RP rips in such patients, and if they are not contraindicated. Now, if there are patients, there are two types of patients. One, which are those that you have to treat them initially, and then there is a chance, so you can give the steroids as an adjunct simultaneously while treating them. And then there are patients post PDT, as Dr. Shishir mentioned, that post PDT there are also chances that there can be paradoxical exudation, something which is called as PDT related acute exudative maculopathy. So in those patients also, usually they present within 2 to 3 days post PDT with paradoxical worsening. So in those cases also, literature has showed that short course of systemic steroids does work if not contraindicated. And there is an possibility of considering subtenance triamcinolone, as well as sometimes even topical steroids also do well in such cases. So we can consider this if needed in simultaneous treatment. Yeah.
Great. So, yeah, so I'll go for the last presentation. After that, we'll take. So, is Aarti ready? We'll go for the last presentation of the session.
Yes.
Yeah.
Are my slides visible?
Yes, Aarti, please go ahead.
Many thanks to the Late Night Retina team for giving me this opportunity. So I'm going to be presenting about an interesting presentation of PCV, where we saw it occurring in conjunction with healed choroiditis. So this was a case of a 72-year-old female who presented to us with blurring of vision for the past 1 month. So she was a known case of bilateral tuberculous choroiditis, which was diagnosed around 20 years back, for which she was treated with oral steroids and anti-tubercular therapy and was under follow-up with us now and then. So at presentation, her best corrected visual acuity in the right eye was 660 with unremarkable anterior segment, whereas her fundus examination revealed a huge subretinal PED with surrounding subretinal heme with multiple subretinal orangish nodules as indicated by the white arrows. Along with it, we could also see the old healed choroiditis patches. There were no signs of inflammation in the anterior or the posterior segment. Coming to the left eye, again the visual acuity was 660 with unremarkable anterior segment. There was a heel typical serpiginous type of old choroiditis scar with a small superficial hemorrhage which was seen in the patient. So this enlarged picture clearly demarcates the heme which was seen. So an OCT scan was done, which showed a tall PED with subretinal fluid, double layer sign, and some subretinal hyperreflective material in the right eye. Coming to the left eye, there was a shallow PED, which could be called as a double layer sign with extensive RP atrophy, very few intraretinal cystoid spaces, and ORTs. OCTA of the right eye was done, but it did not reveal much information. OCT, whereas OCTA of the left eye showed mature vessels, where the on manual segmentation showed us shallow PED along this area of mature vessels, but there was no overlying fluid in these area. So a fundus fluorescein angiogram was done, which showed staining and window defects corresponding to the old choroiditis patches and pooling in the areas of PED. The fluorescein angiogram was of the left eye was unremarkable except for a non-specific leakage in this lesion. Other lesions showed staining and window defects. An ICG was done in the right eye, and we could see these hypofluorescent nodular lesions at 3 minutes. The left eye showed hypofluorescence, which corresponded to the old choroiditis patches. So based on these imaging modalities, a diagnosis of bilateral healed serpiginous choroiditis with a polypoidal choroidal vasculopathy in the right eye and an inflammatory CNVM in the left eye was made. The patient underwent 3 doses of aflibercept in the right eye and 1 dose of aflibercept in the left eye. So this was the OCT of the right eye at presentation. So there was a significant reduction in the height of PED and the subretinal fluid with 1 injection, with further flattening of the PED with 2nd injection with very shallow fluid. With the 3rd injection, there was complete resolution of SRF with near total flattening of the PED in the right eye. So these images show the effect of 3 injections. Whereas in the left eye, a single injection led to the resolution of the intraretinal cystoid spaces, and in the further monthly follow-ups, there was no recurrence of fluid. So we chose to observe the left eye with just 1 injection. So this shows the pre and the post-injection pictures of the right eye. So this is at baseline, and this image is taken after 3 injections, which shows the complete resolution of the PED, resolution of the hemorrhages, and the subretinal orangish nodules, except for a small persisting nodule at this spot. Coming to the left eye, there was resolution of the superficial hemorrhage, and otherwise the fundus findings remain stable. So at follow-up at present, we have more than 1.5 years of follow-up for this patient. There was no recurrence of PCV subretinal fluid or hemorrhage for this patient till now, and no further injections were required. The patient is just put on retinal antioxidants for a placebo effect. So I would like to know any experience of coexisting PCV and choroiditis, if any of the panelists have faced such cases, and how would you have managed this patient? Thank you.
Thank you, Arti, for that interesting case. As all of us know, in this kind of eyes having posterior uveitis, CNVM is more common. Rather, we all of us we would have faced, but something called kind of this kind of large PEDs and PCV kind of lesion, whether it is just a coincidental or anything, any causal relation is there. Can any of our panel, Niroj or Kushal, can throw some light on this?
Yeah,
Sir.
truly a very interesting case actually. One point I'd like to highlight here is that on ICG, this patient had choroidal vascular hyperpermeability also, along with an LGH. So that tells us that it is fitting into a pachychoroid spectrum or a pachychoroid PCV. At the same time, we have seen cases of posterior or choroiditis with CSCR, either during the treatment with oral steroids. They can develop a steroid-induced CSCR along with the pachychoroid. And if you're considering the same spectrum and the same CSC phenotype continued and led to a extreme of pachychoroid of the spectrum, then we could see PCV also developing in eyes which had a history of chronic CSC or complex CSC. So that is one aspect that came into my mind when I saw this case. So any other inputs from others?
Kushal, your take on this?
So the another common factor could be an inflammatory event, because we all know that pachychoroid spectrum patients also have this venous overload choroidopathy. So there is obviously a component of inflammation which is considered to be there for the pathogenesis of PCV. So maybe that could have also triggered this because initially patient already had choroiditis. So maybe some sort of subclinical inflammation might have contributed to development of these polypoidal lesions, probably.
Yeah, so point well taken. So to Aarti, for your cases, like some hypothetical possibility of inflammatory etiology for PCV or a pre-existing pachychoroid spectrum or some steroid-induced CSR kind of thing. That those are the three possibilities. Do you want to add anything? Quick comment from Aarti because you are supposed to be more wiser than us because you have done all the literature study on this. You want to add anything quickly? Any point?
We did a very thorough literature search which shows a series by Dr. Yanuzi, which was published in 1997, where he had published a series of 45 cases, where he saw three cases which had posterior segment inflammation and PCV. That was the only series which we were able to find out. And again, he was also not able to conclude if it is coexisting or inflammation plays a role. But then it was quite some time back. But other than that, our literature search did not reveal any published data on this. So that's why I wanted to present this case here. Though this case has been published in DJO Harvard already, I wanted to discuss because if there is any unpublished experience which has not been brought forward, that was the purpose of presenting the case.
Yeah, great. So thank you, Aarti. And we started with Dr. Yanoji 1982 first paper, and we also ended in the discussion mentioning about Yanoji. Thank you, Aarti, for that. And with this, before I conclude, I'll just summarize. So PCV is more prevalent than all of us think from that editorial and that Dipanshu showed us. Almost 50% of the neovascular AMD in Asian population and almost 20 to 30% in white population actually are PCV. So ICG is the gold standard, but unfortunately not available everywhere. That takes us to the OCT based diagnostic criteria. Remember OCT, not OCTA. So OCT, which is easily available. That's why I'm emphasizing. So the three criteria: tall peaked, like tented PED and subretina, sub RPE, round hyper reflective ring, and on first elevation of the RP. These three gives an accuracy of around 82% and area under the curve 0.9 as evidence from the Jemi Cheung paper in ophthalmology retina. So from OCT itself, we can diagnose PC with good certainty. And the management with the advent of the newer anti-VEGFs, we have a lot of options with us. Aflibercept HD recently will come, and to all of us practice and faricimab and brolucizumab. There is no head-on trial, but all of them work. We should remember some injection is having say USP of larger duration, someone is having a wow effect. So all of them they work. Then we also discussed the role of laser. Thank you, Cecil, for all the points for that. And we also discussed atypical cases or rather less commonly and faced cases like inflammation with PCV. And with this, again, we will continue the show. The part two will come just like Bahubali part two, the PCV part two. Our great friend Avnish will come up with, where people will be wondering why we are not discussing the surgical aspect, because this was the investigational and medical management aspect. So we will come up with the surgical aspect in the coming sessions. So with this, we'll come to the end of the show, Late Night Retina, episode 32 on PCV. Thank you, all the panel. Thank you, all the presenters. And thank you, our core Late Night Retina team. Thank you, YOSI, and all our viewers. And last but not the least, Team Numeratech, Manjula Madam. She has been helping a lot. Thank you all.
Thank you, Dr.
Thank you.
Chitranjan. Yeah, and just one thought, I think we would really want to dedicate this episode to Dr. Uh, Divyansh Mishra. I think Dr. Divyansh has been one of the pillars of our late night team. And thanks a lot to him. And I think we'll come back again as soon as possible with the surgical management. Thank you, everyone. Thank you.
Thank you, Avnish.
Thank you. Thank you, everyone.
Thank you everyone.